and have served as a division director for prehospital emergency healthcare for the past 12 years. My main focus is on really everything having to do with emergency medicine simulation, which is of course quite broad, but I also do a lot of work in the areas of team training, interprofessional education, faculty development, disaster response training, and of course related to what we're going to be talking about today, I have been the medical director for the Advanced Stroke Life Support Curriculum for the last 12 years while I've been here at the Gordon Center. I wanted to take a moment because today is National Nurses Week, and this month is also Stroke Awareness Month, so it's a wonderful month to be talking specifically about stroke education. Of course, all time is good to be talking about stroke education, but just to take a moment to thank all of the nurses and nurse educators who are joining us today for all that they do, both in patient care and in education. Obviously, nurses have a big impact on all of us, so it's hugely important that we recognize them probably every day, but specifically this week. And also in the US, May is National Stroke Awareness Month to bring awareness really to all of our population, both healthcare providers and the public, about stroke and stroke care. And of course, that's what we're going to be talking about a lot more today. So before I get started into the content, I wanted to just go over some of the information about questions. So two types of questions. One is we'll be asking you a few polling questions throughout, and you'll see those come up and you'll have the opportunity to respond to them and obviously to select the best answer that's appropriate to the question. And then if you yourselves have questions, please make sure to use the Q&A function, not the chat function on your screen. And we're going to actually just hold the questions until the end. You can ask them throughout. We have someone that's actually looking at all of your questions and is going to put them into themes so that we answer as many people's questions as possible. It is unlikely that I'll be able to answer everybody's questions, but I'll try to follow up afterwards, or if you have a question, you can always reach out. We'll give you some information on how to connect with us. So we're going to start actually with our first polling question, and just to get a feel of all of you and ask what your primary professional role is. And I know that many of you have many roles, but which specifically you spend most of your time in? And we'll just give everybody a minute here. Okay. Awesome. All right, great. So the majority of you are educators or faculty, which is not surprising given what we're focused on today, but many that are primarily clinicians or administrators or are in SimTech ops. And we have several that are other, I'm not exactly sure who we are, but that's great. Thank you all for joining us to talk about this important topic. So I wanted to start with why should we be talking about this at all? And this is specific to the US, but stroke is increasingly a world public health problem, not just a United States one. And currently in the US, about 800,000 people are affected by stroke every year. The estimation is that about every 40 seconds, someone in the United States has a stroke. So that's a huge number of people, obviously, and has a huge impact on our population. It is still one of the leading causes of death, although I'm happy to report that in the last couple of years, it dropped from number 3 to number 5. So we have made headway into mortality, and we've also made even bigger headway into disability. It is still the leading cause of long-term disability for adults in the US, and this is what we're really trying to impact in a big way with early detection and early treatment. It also has a huge cost burden with about $75 billion per year. Most of this is still in the acute care setting, but obviously there's a lot of costs involved in long-term care for those who are disabled. I wanted to start with a little bit of a testimonial about the course that's specific to the course, but also to clinical care after the course, because ultimately that's the impact that we're trying to make. And this is from a paramedic that took the course in Virginia. And he said, I want to say the ASLS class was great. It's not many classes I go to that I am sorry the class is over. I wanted more. On the other hand, on February 21st, around 8:15 in the morning, I called one of the rescue squad captains to go over a few things. When she answered the phone, she was almost crying. I knew something was wrong. I told her I was on my way. When I arrived, her husband, in his 60s, was unable to sit up, walk, was very nauseous and vomiting, and could not hear out of his right ear. I returned to the rescue squad for the ambulance due to us not being able to transport him by car. I don't need an ambulance, the patient said. I transported him to the hospital anyways. They were unable to find anything and said you've got vertigo and sent him home. His wife and I were not happy. While in the class Tuesday morning and going over the 5 major stroke syndromes, we got to the cerebellar stroke and the light came on. I grabbed my cell phone and texted his new family doctor. Well, today we found out he did have a stroke. Where? In the cerebellum. The family and I want to say thanks for having the ASLS class. So obviously it's great that we were able to make the diagnosis and that he thought about it in this patient so he didn't get worse or have another stroke. But obviously it would have been great if it had been caught the first time around, and that's what we're trying to do, is really get to that early detection so that patients can get as much care as possible. So ASLS, a little bit of background on the course, and again, it stands for Advanced Stroke Life Support. It was developed back in the late 1990s, really shortly after the NINDS trial came out, showing TPA effectiveness for stroke. And it was originally developed by Dr. David Gordon, who's a stroke neurologist, currently the chair of neurology in Oklahoma. And at that time, he was in the middle of a stroke belt in Mississippi and really thought that there was a big need to start training and educating everyone about stroke. But since that time, it's really been put together, revised, and continues to be updated by a consortium of stroke neurologists, emergency physicians, nurses, paramedics, and educators. It's really appropriate for all healthcare providers involved in the management of acute stroke patients. But as you'll see when I talk about it a little bit later, our biggest audiences are really in the areas of nursing and EMS. And it meets or exceeds the requirements for stroke center certification education. And I'll talk a little bit more about that in a moment. It is also nationally accredited in the US by the ANCC, which is the American Nurses Credentialing Center for Nursing CEUs, as well as the Commission on Accreditation for Pre-Hospital Continuing Education, or CAPC, for EMS CEUs. It's revised and updated regularly, and we undergo major revisions every 5 years. Our next one is due to be released in 2020, and one of our goals with that revision is to include more mannequin-based simulation. I'll talk a little bit more about that later. Related to education requirements for stroke centers, so we obviously think that everyone should be getting trained in stroke and getting stroke training refreshing pretty regularly if you take care of stroke patients or have the potential to. But there are also requirements if you work or are trying to have your hospital become a stroke center. And they're listed here for the Joint Commission, which is the most common certifying body, at least in the United States. And then another popular one in Europe and also growing in the US is the DNVGL. And for Joint Commission, regardless of whether you're an acute stroke ready hospital, a primary stroke center, a thrombectomy capable stroke center, or a comprehensive stroke center, there are educational requirements, both for your own staff. And the biggest of these is in 8 hours for the core stroke team and nurses, depending on your level of stroke certification. And the other component is also additionally is reaching out to pre-hospital personnel for training as well as public education. And so the ASLS curriculum really helps in these areas of training both your own personnel and EMS personnel. So I wanted to just ask a general question related to stroke education, and is, do you or your organization use a standardized curriculum for stroke education? All right, so it's almost half and half, so a little over half say yes. and about 46% are no. So that's one of the things that we're going to talk about more about the importance of having a stroke curriculum for all of your healthcare personnel. So I wanted to go over specifics about the course and what we try to cover. So for all healthcare providers, we discuss the importance of early treatment and detection of stroke and reduction of disability. We break down stroke into 5 main stroke syndromes, and I'll show you a little bit more about that in a bit. But then also correlated to the pathophysiology, so what's going on in the brain and the vasculature, as well as the clinical signs that they're seeing. And part of our goal, because we are primarily an education and simulation center, is to distill all of the information. The brain is clearly very complex, and stroke can be, quite complicated as to what's going on in the brain, but really to distill it into what clinicians are likely to see and have them be able to take away, what are the major stroke syndromes that I'm likely to see, and be able to put the symptoms and the signs together. We also focus on an evaluation to identify stroke, and there are many of these. I'll talk a little bit more about this, but again, related to the NIH stroke scale, which is the gold standard, and now the many other stroke scales or exams that are out there. We go over the major ones and then have an opportunity to practice whatever you're using locally. And then we also discuss the location in the brain and the severity. And then, of course, we talk about TPA indications and contraindications, and that's for all providers. And then we have for pre-hospital providers to define the chain of survival and recovery, mostly focus on the 8Ds from the AHA, the principles of stroke management related to the current standard of care, and then determining when to call a stroke alert, and then discussing what the nearest appropriate facility is for that region. And then the other piece, which I think is hugely important, is communication, right? So if we receive in the ED a standardized comprehensive report from EMS about what's going on with the patient, then we are much more likely to activate the stroke team early and all of that. So teaching EMS personnel how to appropriately communicate all of the components to the ED is really important. And then for hospital providers, in short, we really cover everything from the moment the patient either arrives in the ED or is identified in the hospital, all the way through hospital discharge and everything that needs to happen. It's a hefty module with a lot that gets covered, which is one of the reasons that we've kept the course separate for EMS providers and hospital-based providers for that component, because we feel it's so much information that we really want EMS to focus on detection and management and understanding the things that they need to do, whereas all of the things that have to happen in the hospital related to initial care, but then all of the supportive care, and then etiologic evaluation and secondary prevention, as well as rehab and therapies are really, really important. So we go over all of that. And so this is what it looks like. And this is not an agenda, but just all of the different components. We have several didactic lectures that incorporate videos and animations and graphics to try to keep it interactive and keep everyone engaged, because we know we don't want to have people sitting around for too long without having them either interact with us in some way or actually get up and practice. And so we really break these up along with the practice sessions and the video case workshop. But they are stroke facts and rationale for urgent care. Again, to get that, this is really important and emergent, and we need to have an urgency to treatment of these patients. We do a focused neurologic assessment, and I'll talk a little bit more about that. Major stroke syndromes and stroke mimics, and then 2 stroke management, one focus on pre-hospital and general principles, and another one on emergency department and inpatient care. And I'm going to show you little excerpts of each of these. Obviously, I can't go over the entire 8-hour course in our 45 minutes or so that I'm going to talk, to give enough time for some questions, but I want to show you some of the components. And then we have practice sessions where the learners actually practice the different neurologic assessments, and we focus on the Cincinnati or the FAST exam, and then one additional one, which I'll talk about what we do here. And we recommend that folks go on and use whatever they use locally to practice as well. And then we do one with stroke syndromes, and this is where we have standardized patients or actors actually portray the stroke syndromes, and then the learners go around to each of the stations, determine whether it's a stroke, most likely a stroke or a stroke mimic, and then have a discussion about most appropriate facility, likelihood for TPA candidacy, what's the best treatment for them, and all of that in an interactive, hands-on way. And then we also have a video case workshop, and we standardly do this in the EMS course, but then we also have analogous videos for the hospital-based providers if you have a hospital-only audience and you have additional time. And so this is where they're shown 7 different cases, and they're shown the field. For EMS, it's in the field, and then in the back of the rescue, and then radio report. And each of those things is discussed, and they initially have to figure out, is it, a stroke? Most likely, is it a stroke mimic? Most of them are strokes, but there's a couple of stroke mimics. And then we also talk about TIA and the importance of identifying those patients and making sure that they get etiologic evaluation for secondary prevention, so they don't go on to have an additional event. And then we end with a review game because, hey, we have to have a little fun too, and it's a great way to have a little competition in the audience, but also review the main important points before the post-test. So the course begins with a pre-test and ends with post-test to make sure that we are meeting our learning goals as a curriculum and educators. So I'm going to show you a little bit of each of the different lectures now. So stroke facts and rationale for urgent care. I actually, the slide that I started with had some of this as well, which is the 800,000 and the every 40 seconds someone has a stroke was taken from the curriculum. We start by talking about that it does make a difference, right? That emergency stroke care makes a huge difference. Historically, there wasn't a lot we could do for stroke patients, but now with every year that passes, there are more and more options for these patients, and we can make such a huge impact on both mortality, but even more importantly on the disability piece, because if we can catch these strokes early and treat them, then a person can go on to have no disability as opposed to having been majorly disabled. And these are things like being able to feed yourself or speak or move half of your body, so that it's really a big deal, of course. So we try to liken it to acute MI and trauma because most people understand that and have an urgency and understand the systems of care associated with those. And we're trying to really create the same urgency with stroke. And of course, the goal is to have all of us lead the way. It includes public education. We know that if the public doesn't identify that this is likely a stroke going on and activate the EMS system, then they're not likely to get the care in a timely way, improve field detection and management, and then decrease time to treatment, and then increase thrombolysis and endovascular therapy for the appropriate patients. We go on to discuss stroke definition and types. So we know that all strokes are related to a dysfunction in a blood vessel, but the majority that we see are ischemic in nature, and this is pretty true throughout the world, although the percentages might be a little bit different. And we do also review pediatric stroke, where the percentages are much different, especially in the first year of life. But most stroke that we see is ischemic stroke, and then we talk about what causes it. And we do also review hemorrhagic stroke and the management of hemorrhagic stroke in the course. Again, for ischemic stroke, we go over what the pathophysiology is with some nice graphics showing what happens. And I'll show you a little bit of an animation later with regards to TIA. Again, we focus a lot on what areas are salvageable and the time sensitivity of it all. So we focus a lot on the penumbra, and they hear this throughout the course, save the penumbra, which is the area that has reversible ischemia, right before it becomes infarcted. And then another thing to drive the urgency home is this idea that, with a large vessel occlusion or an LVO, every minute the patient loses about 2 million neurons. And I don't know about all of you, but I like to keep all of my neurons, and we like to do the same thing for all of our patients. So time is really, really important in this. And at the same time, we've also learned with recent studies that some patients have salvageable tissue and cells, long after. And so there are more and more options, but the sooner the better for all of these treatments. And then we go over the chain of stroke care and talk about the importance of each of the components in stroke management, right? So again, we talked about the public needs to know what's going on and to activate 911 so that they don't come in, hours or a day later or drive themselves in when they're likely having a stroke. And then EMS has to be able to rapidly diagnose, manage, and transport to the best appropriate facility. And then in the emergency department, a lot happens, and really efficient stroke centers have, again, started giving TPA and the CT scanner, try to get EMS to go straight to CT with the patient to try to decrease all of these potential delays that we'll talk about a little bit later in the systems of care. And then cath lab or endovascular lab if the patient is a candidate for that. And then onto a stroke unit or stroke floor, depending on the facility, and then ultimately rehab clinic, which is follow-up, which is very important because we know that these patients, if they've had a stroke, have risk factors for stroke, and we want to implement secondary prevention and mitigate those. So we talk about each of those components really throughout the course, but introduce it early. And then related to the focused neurologic assessment for stroke, we talk generally about the NIH stroke scale, again, as the gold standard, and then go into the screening exams that are used quite a bit. So the Cincinnati Prehospital Stroke Scale, or the FAST exam, which is face, arm, speech, and T for time, is the first one that we review as a screening exam, and we go over again lots of nice pictures so that folks know what it is they're looking for. When folks look at facial droop, they're often confused and they think like in this patient, this would be the abnormal side, right? But it's not. That's the normal side where all the muscles are actually contracting when you ask the patient to show you a big smile, right? So in this case, the abnormal side for this patient is the right side where everything is flaccid, and this is a right facial droop. It's one thing to talk about it, but when we see it, then, both in the pictures and then also in the standardized patients, it really drives it home. And again, for this piece, it's the arm, and then the last, so arm weakness or drift. And then the last part, which is related to language and speech, right? So you ask them to say, you can't teach an old dog new tricks. And the goal here is to determine whether they have aphasia, which is a language center issue, in the up in the cortex, or dysarthria, which is related to motor weakness of the tongue and oral muscles that you have. It's a dysfunction of articulation, but language is okay. And this is something that really confuses people, right? So we decided to actually have videos to show this. So I'll show you a little bit of each that we show in the course related to dysarthria and expressive aphasia. So here we are with the dysarthria video, and what you'll notice is that she has no problem answering the questions or producing language, but you'll notice that it's a bit muffled, almost like if she had something in her mouth. So the speech itself is not clear.
Can you tell me how to get from your house to the hospital? Yes, I drive to I-95 south to 836 west. And then I turn right on 12th Avenue to 16th Street and turn right, and the hospital is right there, Jackson. Can you tell me what this is? Just a squash. Right. Can you tell me what this part here is? This the lung fan. Can you tell me what this red part on the cover is? That's spots. Can you touch your nose and then point to the ceiling?
So again, this patient can tell you directions, she can name things, she can follow commands, so it doesn't have a language issue, but her speech was a bit slurred, right? And then this patient with expressive aphasia, what you'll notice here is that she actually can articulate quite well when she does get words out, but has a lot of difficulty being able to get words out. And what you'll notice with this isolated expressive aphasia is that she knows what she wants to say, but she can't get it out. And so she may say things that are similar, words that are similar, or or related, say numbers, if you ask for something related to numbers, and they often get very frustrated, right? Because they know what they want to say, but they can't actually produce the language.
Can you tell me how to get from your house to the hospital? Street. The interstate. Number. tell me, what do you call this? Okay. All right. Now touch your nose and point to the ceiling.
So she can also follow commands because she understands language. And there is a type of aphasia where that's receptive that you don't understand language. She can understand language, she just can't produce it. And so again, it's just an example of how we use videos and examples to really show what we're trying to have them understand. So one of the exams that we use in the course is called the MEND exam, which is the Miami Emergency Neurologic Deficit Exam, which takes the face, arm, speech components of the Cincinnati or the FAST and adds the components that they miss. So basically, when they put the Cincinnati prospectively to see the sensitivity and specificity, it was in the mid 60% or so for sensitivity. And the reason is that it misses posterior strokes, those involving the cerebellum and the occipital cortex. And so the MEND exam was developed around the same time as the ASLS course to incorporate those components, but still be brief and still be a screening exam. So you'll notice that we have visual fields and horizontal gaze, as well as sensory and coordination to try to capture some of those additional pieces that the quick FAST exam misses. And it's estimated about 20% of ischemic stroke involve the posterior circulation primarily. So we can miss about 20% of patients if we don't do a slightly expanded exam in some way. So we use this during the course, and they get to practice that during the stations. And again, we use quite a few videos during the didactic portion. So here's another one, an on-scene basic exam, which is again the FAST for the Cincinnati.
Roger, paramedics, let me help. What's on the road, my boss? What's he doing? He just seems confused and staring out in the distance. We're gonna examine. Okay. My name's Alex, I'm a paramedic. Can we help you? What's your name? Dark. What's his name? His name is Mark. Mark. Okay, Mark. We're gonna ask you a couple of questions. Is that okay? Tree. Okay. Now, Mark, I want to see if you can repeat this phrase. You can't teach an old dog new tricks. Truck. How long has it been like this? We just finished the meeting, so less than 10 minutes. Gabriel, we have a low-to-go situation. Can you bring the stretcher, please? Now, Mark, can you give me a big smile? Okay, very good, Mark. I'm going to hold your arms out, okay? I want you to close your eyes. I want you to keep your arms out while I count to 5. Ready? Go. 1, 2, 3, 4, 5. Okay, very good, Mark. You open your eyes and you relax. Does he have any medical history? I think he has hypertension, but I'm not sure. Is he taking medication? Not that I know of. Did he have any seizure activity? Not that I know of. Did he fall down? Have any trauma? No, I just found him very confused and staring at him. Okay. We're going to take him to the hospital. Can you come along with us? Yes. Okay, great.
So again, showing all the components on how to do the exam, and then a reiteration on what this is: a left hemispheric stroke syndrome with aphasia, right-sided weakness, left gaze preference, etc. They then do, we have video for the expanded exam in the rescue or ambulance, and then the radio report to the hospital. So all of those are included. For major stroke syndromes and stroke mimics, as I referenced before, we break it down into 5 main syndromes: left hemisphere, right hemisphere, brainstem, cerebellum, and hemorrhage, to discuss the common symptoms that they'll see with each. And then we also review brain anatomy in general, which I don't have here, but also specifically arterial supply. Again, because there's increasing endovascular therapy, but also for them to understand what vasculature or what distribution is likely involved when we're talking about a left hemispheric syndrome or posterior cerebellar syndrome or things of that nature. And this is one of the slides that we use related to one of the syndromes. So here's a left dominant hemisphere. and what are the findings that they're likely to see. They're likely to see right hemisensory and hemisensory loss and hemiparesis, a right visual field deficit, but then have their gaze preference be to the left, and then aphasia, because we know in about 75% of the population, their language center is on the left, so it's going to be involved. And the goal here is that if they find a patient with right arm weakness or aphasia, they know to start looking for the things that are likely associated with it. Not that every patient's going to have all of the symptoms, but they may, and they can really start putting that together. Here's another one related to the brainstem, where of course a lot of things can be involved. And then we also review stroke mimics in that lecture and talk about how they're different from an acute stroke. Things like hypoglycemia or a brain tumor or seizures with paralysis, things of that nature. So we discuss all of those things. And then in stroke management for pre-hospital and general principles, we again talk about the chain of survival using the 8 Ds and all of the components that need to happen. We also discussed TIA and the importance of transporting these patients, even if they're, by the time EMS arrives to them, they may have either have rapidly resolving or already resolved symptoms, but they have a perfect story for having had a stroke. Again, talking about the importance of etiologic evaluation and secondary prevention for these patients. So a nice animation here showing what actually happens, and we use kind of a TIA animation for both because this is also what happens in ischemic stroke. It's all the same pathophysiology. So a blood vessel gets occluded by a blood clot, either locally or that's embolized, and then it cuts off circulation distally from there, where brain cells start to die. And of course, in TIA, it spontaneously resolves, but if not, this is what we need to do for the patient, right? Either using thrombolytics or endovascular therapy, we need to remove that clot so that the brain gets reperfused. We also spend a good amount of time discussing transport decision and destination, because this is a big piece of what EMS has to do these days. Because we teach the course really all over the world, but all over the US primarily, and there's big variations depending on what you have available to you. We go over what the general best practices are, but then have an opportunity for wherever we're teaching to discuss what they do regionally, right? Because it depends on whether there's air transport, which types of hospitals you have nearby, what your transport distances are, right? So all of these impact what's going on with the patient. Are they acutely decompensating and need airway intervention? You know, all of those determine what hospital you're going to, you know, what type of hospital you're going to try to get them to. But this is the current Joint Commission and really the most commonly used in the U.S. Classification of hospitals, with acute stroke capable hospitals or stroke ready hospitals, primary stroke centers, thrombectomy capable, and comprehensive stroke centers. And then we also talk about advanced technologies. So telemedicine has been used for a while now on the hospital side to help support hospitals to be able to give TPA and for guidance from neurology or stroke specialists. But it's also being used in the field now. And this is an example from Monroe County Fire Rescue, which was started by one of my coworkers here who also works for Monroe County. And they were flying out trauma patients, but because the keys are so spread out and the hospitals aren't 24/7 CT capable and don't have specialists on call or there, they started flying out stroke and STEMI patients as well. Of course, flying it means cost and risk, and so they implemented a telemedicine system whereby the stroke neurologist or fellows actually do an exam after the patient is identified by EMS before making the ultimate decision to fly the patient out, which has been really successful. And then, of course, now there's mobile stroke units with the goal to do pre-hospital thrombolysis, and these have become fairly popular. Of course, there's a big cost associated with them, but they actually have CT scanners, and we go over, you know, all of the latest technology and therapy. And then for the ED inpatient care stroke management components, again, we go over everything from the moment the patient arrives in the hospital or is identified, and all of the components. We have a nice mnemonic called stroke for everything that needs to happen, not in the correct order, so we can make it work. But really, it's addressing all the different aspects of care for each day and having all your multidisciplinary teams set up and ready to go, as well as stroke order sets and designated stroke unit. We review hypertension and acute ischemic stroke, which is another area of challenge for healthcare providers, and really try to distill it into these three categories of patients that they're likely to encounter related to having an elevated blood pressure and what they need to do. So we go over each of those, which to really clarify it for them. Again, we go over supportive medical care, and we don't want to save someone from their stroke and then have them have a DVT or a PE, and then talk about the things related to that damage the penumbra that we want to decrease the likelihood of, such as seizure and hyperthermia. We then go over etiologic evaluation and go over the common causes of stroke. This one's for ischemic stroke here. And then the therapy, of course, depends on the cause of the stroke. So we need to identify that, and we go over all of the things that are likely to happen with the patient related to determining their etiology. Is it hypertension? Is it AFib? Is it diabetes? Is it lifestyle issues? Hyperlipidemia? All of these different things that go into possibly causing a stroke. Okay, so here's another question for all of you. Do you or your organization use simulation for stroke education? Okay, so here a majority, it's almost 50-50, but a majority says no, about 57% says no, and a good percentage of you do. One of the things that we do as part of the course and in training healthcare providers is the use of standardized patients, and I'm going to talk about the mannequin-based simulation as well in a moment. But there are certain things, especially for stroke, that mannequins don't do well, and that's related to communication and then the actual stroke syndromes. Unfortunately, not yet. We'll probably get there someday soon, and once we incorporate a lot of virtual reality, we can make all this happen, right? But really having facial weakness or arm weakness, things of that nature, the mannequins don't do well. Ataxia, things like that. And so for us, we use standardized patients or actors for all of that, and really teach them. And related to the course, because we do it in many different places and not everyone has access to standardized patients and actors, we teach the instructors how to portray the different stroke syndromes and give them a lot of case detail of what it is that they need to portray, so that they can do that effectively. We obviously don't want to confuse people. And so they actually portray the stroke syndromes, and then also for practicing the stroke exam. We use standardized patients for all of that. Also, of course, your confederates like families or witnesses, and then for the stroke history and consent, standardized patients are really great for all of that, and we use those. Another question for all of you: does your organization use simulation for endovascular skills or team training? Okay, so I'm not surprised, right? So it's about 80% is no, and it's because it's fairly new, and although endovascular therapy is increasingly growing, there haven't really been a lot of options. But I'm going to show you some of the exciting things that are happening now, that some places are doing, and hopefully some of you will be doing in the near future if you're not currently doing it. And one other question: does your organization use simulation for stroke systems of care training and/or assessment? Okay. And this is great. So more of you are doing this, but still the majority, around 66%, aren't. So I want to talk about both of those because I think the impact using both of those are really important. And this is where I think the mannequin-based sim is really, really helpful. So how do we use mannequin-based sim in the context of stroke patients? So critically ill patients, obviously, at that point that are not mobile and you're not doing necessarily stroke exams, we're trying to manage multiple systems things going on, airway management, things of that nature, pre and post TPA and endovascular care, and then the endovascular skills and team training that I asked all of you about. So there are now simulators, including SimMan Vascular, that actually allow the entire team training, but also to train on endovascular skills for whoever's doing your endovascular therapies, whether that's interventional radiology or neurointerventionalist or cardiac interventionalist. There's a lot of discussion, but mostly it's interventional radiology and neurointerventionalists right now doing them. And we want to keep their volume up. So of course, if you're at a place that doesn't see a ton of volume, or also just for refinement of skills, using the simulators are hugely helpful and impactful for that. But also, just like in the OR or in the ED or really anywhere that we care for acutely ill patients, there's a whole team around that needs to be trained. And so it also allows for team training around the procedure that's being done and creating efficiencies, which are so important. And then the other piece that I asked you all about is the team and systems training. I've definitely seen some publications related to this specific to stroke. We've seen it related to other things such as rapid response team or resuscitation responses. But one of the recent, not publications, but presentations that I saw related to this was at IMSH this year with a group in Norway who was able to reduce their door to needle times down to 13 minutes by doing regular weekly team and systems training, where they started with EMS bringing a patient, and they actually used blended sim, where they actually used their patients who previously had a stroke as their standardized patients brought in by EMS, and then transitioned to a mannequin, went to CT, did their TPA, including, where is it, how to mix it, all of those things that need to happen. And they look at times for all of these things, of course, and outcomes, and then go to the endovascular suite if it's appropriate for the patient and do that component. And they've been able to drastically reduce their times by doing these regular trainings. So we know that it can have such a big impact when our entire system and these complex, time-sensitive things have to happen. So using mannequin-based sim for all of these is really, really useful. So I want to go back to ASLS for the last few minutes and just talk a little bit about where we are and where we're going. So this actually has grown since I put this slide together, but we have around 122 training centers, mostly all over the U.S., but also in some countries, which is now growing. 1,124 certified instructors, 26 states, along with Mexico, the UK, Hong Kong, Saudi Arabia, and India. And we're currently working on an initiative with the Boehringer Ingelheim Foundation through their Angels Initiative to bring it throughout Europe and other developing countries. So that's a really exciting thing as we grow and bring stroke education to more and more people really throughout the world. And here's where we are the last 2 years. We trained about 7,200 people in 2017 and nearly 8,000 in 2018 with the course. So it's really exciting to show, and it continues to grow. And this is the number of EMS personnel and the number of hospital-based personnel for each year. If you want further information on ASLS, here's a couple of websites that you can go to, and you'll get a follow-up email with some information when you registered for the webinar. But just a couple other quick things. We use a train-the-trainer model. We are a small simulation educational center at the University of Miami, and maybe not completely small by simulation center standards, but we know we can't train the entire world as much as we'd love to. And so we use a train-the-trainer model, very akin or similar to the AHA or NAMT or ATLS or other courses like that, where we train instructors, and then your organization becomes a training center, and you go on to teach. And really the investment is related to training of instructors, which we do through a 2-day process, They take the provider course and then an instructor course, which is focused on all of the logistics as well as all of the content and educational components of teaching the course during the second day instructor course. And then the curriculum package piece to have all of the components to teach. And I wanted to go over a couple of other things related to this and course effectiveness. So we, of course, do course evaluations for every course that we do. This is for the last few years. Each component, which is about 20 altogether, we asked them about every component about the course, has an average of 4.93 to 5 out of a 5-point Likert scale. And some of the excerpted comments. This course made more sense of strokes and stroke care than any EMT medic text I've used before. The staff was amazing and kept the content moving and entertaining. Overall, one of the best classes I've ever taken. This is the best stroke course I've had in 28 years of EMS. The instructors were very knowledgeable and entertaining throughout the course. It was an honor to be a part of this class and course. This course far exceeded my expectations. I learned better by hands-on, so the interactive portions were helpful. Again, a couple other comments from nurses on the provider course. The course was very informative, and I feel prepared to educate my nurses in order to create a stroke-friendly and prepared environment. Wonderful presentation, well executed, highly informative, very engaging. I think all new neuro-ICU or progressive care RN need to take this course. As a stroke coordinator, I wish I had taken the course on day one. One of the most informative classes I have ever attended. Instructors were amazing. We do get a lot of compliments on our instructors, and some of that is selection, and then of course all the faculty development that goes into it. Again, related to the instructor course, here are all of the average components are in that range, so all very close to 5. This was the best taught class I've ever been to, well organized and focused on teaching the appropriate material needed to be known and related to the other students. Great course. It really exceeded my expectation. I also was able to identify my strengths and weaknesses as an instructor. I really feel like assessing a stroke patient now. Overall, great education. This program is a lot of great information, very focused, a program that I will encourage those in my clinical area to take. We also presented on course effectiveness at the International Stroke Conference last year, and this was at the time that we had nearly 10,000 learners up until 2017. We obviously have a lot more, and we started basically at the point of the when we released the new curriculum, which is at the end of 2014. Again, about 9,600 participants at that time, 62% nurses, 34% pre-hospital, 4% physicians and PAs. And I should mention that we also have had a fair number of respiratory therapists, physical therapists, et cetera, that are involved with stroke patients also participate in the course. With the significant pre to post course knowledge gained from 64% to 89%. And then there's been other published studies, and I've only excerpted a couple here. One was actually done by Dr. Gordon back in 2005, and this was looking at specifically training of pre-hospital providers using blended learning way back before probably that was as common a term as it is now. They evaluated the skills components of the course before and after, and showed that there was a really great improvement from before and after participating in the course. And this was another great study that came out, actually done by Lehigh Valley in Pennsylvania, and they looked at implementing ASLS for the EMS providers and looked at the numbers of stroke patients detected, as well as the number of stroke patients that ended up getting thrombolysis and endovascular care, and that it came to the hospital after implementing the ASLS program with big increases in all of those areas. And in 2019, so this year at the International Stroke Conference from Salinas Valley in California at the Best Practice AHA conference, the stroke coordinator there presented using the MEND exam by nurses and showed that there was a huge increase from 20% regular documentation of the stroke exam to well over 90%. So of course they trained their nurses in how to do this, but also by using a simplified exam that they could track patients more easily and complete, that they were comfortable with, they improved their documentation and following of the patients by nurses significantly. So that was really exciting, and we hope to see a publication on that soon. And excuse me, the last testimonial I'll share before I take your questions, is another clinical testimonial. So we get a lot of great feedback on the course, but of course, when we hear that it's had an impact on the clinical management of patients or helping detect other patients, that's the biggest piece for us. I wanted to share a great story in regards to the ASLS class in Missouri. There was a captain in the class that was a little bit of old school in regards to just transport the patient mentality and let the hospital experts do their job. He was impressed with the course, the instructors, and the MEND exam, even though they only do the Cincinnati Prehospital Stroke Scale. He was on shift, and after the class actually had a stroke call, to which the crew transported to the hospital, even though the FAST was negative, but she seemed weak. He found the patient to be having a cerebellar stroke after he performed the MEND in front of his crew members and hospital staff who didn't know what the exam was. He came into the instructor course as a solid believer and strong supporter. We are making a huge difference. And of course, that's what it's all about, right? We all want to make a huge difference and help the healthcare providers that we train make a huge difference in patient care. So I'll try to take some questions now. Thank you all for your time and attention. I know everyone is really busy, so thank you for taking out the time to hear me speak about stroke in our ASLS course. Thank you. All right. Okay, so one of the first questions we had is, how does one get certified in ASLS? So the best way to get more information is to go to that asls.net or our Gordon Center site. And again, Laerdal will also be sending more information about that and follow up to the webinar. But you basically, if you just want to get certified in the course itself, you take a provider course. If you want to go on to teach it, then you would take a provider and instructor course and align yourself with an existing training center or have your organization become a training center. So the qualifications to become an instructor, it's actually all laid out in our guidelines, but you basically have to have a clinical background, and so that's usually in EMS or hospital-based medicine of some sort. We don't say you have to be a stroke nurse, so you can be an emergency department nurse or other areas, as long as you have exposure to stroke patients, and then it's really going through the course. You have to meet a minimum passing score on the provider post-test course, and then you can go on to participate in an instructor course. And our certification period is 2 years, as are many other courses. Of course, we know that more frequent interventions are better, especially if you're not exposed to these patients as often. But the certification for the course and the instructor status is a 2-year certification. For instructors, we require that they teach a minimum of 4 courses in a 2-year period. Again, that's to stay familiar with it. We do have a very robust instructor manual that we give our instructors that have all the background information for each of the course components and slides to support them in teaching the course, especially if they haven't done it in a couple of months. The other thing is that we then do an annual webinar-based update, sort of similar to what you're doing now, but related to all of the latest science and how it impacts what's being presented in the course. And then how do you get updated DVDs and materials? So anytime that we release a new version, if you're already an existing training center, the training center then is asked to actually, so not just that they can, but they need to get the new DVD and material. And at that point, and course materials, and at that point, we release another webinar for an update of all of the instructors into the new curriculum as well. We know that not everyone can come to Miami or make it to a place where instructor training is happening. So once you've done the initial instructor training, we try to do as much of the updates remotely so that folks, obviously don't have to travel again. Although I know many folks, especially in the northern climes, love to come to Miami. So somebody asked sort of about specific stroke care stuff, when to start TPA based on symptoms. I'm not sure I have the full question there, but basically we've really laxed a lot of the TPA criteria to try to get more patients treated, because even with all of this awareness, we're still only treating a small percentage of all potential candidates. I think increasingly, if patients make it to the hospital in a timely fashion, more and more of them are getting TPA if they're candidates. But the public education piece is huge. The EMS education piece is huge. the nursing home and home health aid and all of that, so all of those components. One of the things that we are looking to do is to develop a 4-hour, sort of shorter course module called Essential Stroke Life Support for folks that work in nursing homes or home health aides and are likely to be around patients that may have a stroke, to help them identify that the patient is having a stroke and ask for help. But the current windows for TPA are 0 to 3 hours and 0 to 4.5 hours. I'm not going to go into all the details of the criteria for those, but the bottom line is the sooner the better. And so if someone is identified and they arrive and they're a candidate and we rule out that they're having an intracranial hemorrhage with imaging, so usually a CAT scan, and they don't have any other major contraindications, they're going to get TPA. And that's really where we want to get everybody to. The determination of which type of center to take the patient to, right? So this is a big discussion right now in the stroke world in general, and there's been several scales that have been developed to try to help triage patients. That means identify patients that are having large vessel occlusion, to bypass primary stroke centers and take them to either thrombectomy capable or comprehensive stroke centers for intervention. The problem is that where these scales are good, they're not great, and so it really depends on, again, regionally, what centers you have available to you. We live in a very urban center with many comprehensive stroke centers, and so many stroke patients end up at comprehensive stroke centers. Even, we're trying to do the triaging as best as we can by EMS, but it really, if your time difference is 10 minutes, that's very different than if your time difference is 45 minutes, right? Those have big implications. And so we need more hospitals that are willing to be acute stroke ready or primary to be able to give TPA, so that patients are closer to those hospitals, and then really help determine when we need to bypass those places. But again, it's dependent on the distance to those places, what's going on with the patient, and then what resources you have to get them there. Do you have do you have helicopter or other air medicine ways to get them there, or you can actually do it by ground? So those are really good questions. And somebody asked, are you recommending the CPSS over the med? So no, what we actually recommend in the course is that everyone initially does CPSS, which is a Cincinnati Prehospital Stroke Scale, or the FAST exam as an initial screening exam. But then we tell them that you should do an expanded exam. So whether that's the MEND or one of the triage scales in the back of the rescue, or we also tell them, if you notice, right, as you're talking to the patient, initially evaluating them, if you're concerned, like these clinical cases that were shared with us, they kind of felt like, okay, the Cincinnati or the FAST was negative, but there was something going on. Then we tell them to do the exam at that point, right? To do the expanded exam. And it's often when they'll capture either sensory or ataxia or visual field issues. So we're recommending that folks do both. The FAST is a great initial screening quick exam, but again, it's going to miss those posterior strokes. And so it's important to try to incorporate those as well. So not one over the other, really both. And of course, the MEND exam incorporates a CPSS, so it also ends up acting as an additional sort of point in time assessment for the patient to figure out if they may be getting worse, if they did have abnormalities on the Cincinnati, or maybe getting better. So those are all really good questions. Do we have any other big questions? If not, we're gonna go ahead and end this. We're actually right at 2. So go forth and simulate, as we like to say, spread the stroke gospel, and educate your folks. Use your simulations to both train healthcare providers on how to detect and manage stroke, and also use it for your endovascular skills and for your systems training to try to improve your efficiencies, right? As you do these things, you're going to identify where there's opportunities for improvement, and it's a really great way to do it. Thank you all so much, and again, happy Nurses Week, happy Stroke Awareness Month, and for those of you involved in EMS, happy EMS Week. It's coming in 2 weeks. Thank you.